Thank you, Jean-Michel, for this opportunity. So I'm going to discuss about complex intervention. Complex intervention is a widely diffused issue in healthcare. And I think that we have a particular issue in intensive care with this problem. Here is a meta-epidemiologic study where they extract the p-value of a lot of published study in PubMed. And if we look at the orange line, we see the randomized controlled trial. Between 90 and 95% of published trial have a p-value lower than 0.05. So a lot of published results are positive. But if we do the same thing in the topic of intensive care, we find in the period and in their search 72 trial, and what we see is that 80% of the published randomized control trial didn't show any positive effects on mortality. So we are probably in intensive care dealing on particular issues that we need to address if we want to show positive effect when they exist. So what is complex interventions? Complex interventions are situations where several interactive components need to interact together for the intervention to be effective. The complexity relies on several problems, and the more interactive component there is in a single clinical situation, the more the issue is complex. The more stakeholders are involved, the more complexity exists. And if we deal with different outcomes, there will be different methods of evaluation, and it probably also increase the complexity. So I think that sedation is a complex intervention, and I take at random some active component ingredients that can exist in sedation. So there is an indication, you do or do not daily interrupted sedation, you use one molecule or another at a different doses, and you can use scales, which level in this scale. So we have to encompass all this issue when we are conducting randomized control trial in this clinical indication. When we overlook complexity, it can raise several kind of issues. I will discuss two of them. The first is about reporting. If we overlook complexity, we won't be able to properly describe our intervention. And if in the published paper we don't properly describe the intervention, this intervention will be difficult to replicate in a further trial. And it will also be impossible for stakeholders to implement this intervention in daily care. So issue about reporting, and also issue about treatment effect evaluation, because if we miss one active component in the intervention, this component will be present or absent for each patient in the randomized control trial in both arms. And it will introduce a bias in the result, and we won't be able to know what the treatment effect is related to. Is it to the treatment I evaluate, my component, or to other components that I missed? So there is guidelines to address this issue. The first published is in Annals of Internal Medicine by Isabelle Boutron from Paris in 2008. It's a consort for non-pharmacological treatment. Obviously, sedation is a non-pharmacological treatment. Previous speaker discussed about it, and more. It will be trials about non-pharmacological treatment, even if they include one component which is pharmacological. And the other publications that can help researchers to describe complex intervention is the TIDE checklist, which recommend to, before the trial, to decompose the intervention, to understand how each component interact with each other, and to be able, in the treatment effect to understand the reason of the effect. So we have for each situation to understand who is doing the intervention, how the intervention is planned, why I use a component and why and not another. So thank you, and I hope it will raise some discussion.
Yeah, thanks so much, Arthur. I think it's quite new and it's quite complex to understand what you deal with. Maybe to join your presentation, Thomas, we can say that in the SPY3 trial, they do not look at all the components, and first of them was what is the indication of deep sedation? And maybe if you have to restart the SPY2 trial, what do you change, Thomas? What will you change?
I think it would need a clear algorithm to stipulate what is the indication for sedation. The choice, the selection of included patients must be the first step, as you said. And maybe I would guide physicians with the indication of sedation.
It sounds like another trial that we discussed with Jean-François. One of...
I have a comment.
Hi, Peter. Give you your input.
So my vote from Sweden. I would say yes, it could be very good to guide physicians, but on the other hand, maybe it should be the physicians who guide what patients should be in a trial. If you as a physician work in the middle of the night, you just intubate your patient, and you consider that this patient needs to be somewhere else than where DEX will take you, maybe this is not the patient for the trial.
I think it's right. It's what are the patients included in the trial, and maybe it's one of the reasons why observational trials have better results than a randomized controlled trial. First, because all the patients are included. Second, because we may look to all the components of sedation. Jean-François, could you just give us a word about the ABCDEF trial published by the group of Wesley?
I think it's, as mentioned by Peter, is a good approach. It's a bundle of care which echoes with this, the PADIS guidelines to consider the multiple approaches for the patient, and including the pain, including delirium, including comfort, including family involvement, and so on. So I think that's and a paper was published on how much was the impact of the gradual involvement in this bundle of care on the delirium and on the ICU duration of stay. So I think that it's a good approach to consider multiple components related more or less to sedation, and to look if I take all these components, I will do better for the patient with strict endpoints. So it's a good approach.
Thanks, Jean-François. I think it's a good conclusion. It's time.
Can I add to that?
Short comment, Peter. We have less than 1 minute.
No, I really like the ABCDF as well. They don't go into, they don't dictate when you should give what. They just tell you, think about what you're doing, reevaluate from day to day, and aim towards getting the patient out of the ICU. And that's a very healthy approach, and that's going to last long, the ABCDF, thanks to that.
Yeah, sure. I think we have to keep in mind that patients do not come in the ICU because they are not able to sleep. They came in the ICU for something else, and sedation is just a tool to help us to give treatment to the patient and to improve outcome. So thank everybody to follow us. Stay connected with the HISFAR, and we will be back in a few minutes for the next session. Bye-bye.